Hello, this is Bridget Gant. This is a case study presentation for case number 2, Miss LG. Miss LG is a 51-year-old divorced female who presented to the emergency room requesting a dermatological evaluation for flea infestation. She was admitted to inpatient psychiatric services after insisting she was not safe at home and an unremarkable skin examination. Miss LG perceived brown insects burrowing into her skin, walls, covering rugs, and her mattress. She stated she discarded a bag of clothing due to hearing fleas rustling and scratching inside. She reported problems sleeping and spending 36 hours frantically cleaning her home. Miss LG stated she showered multiple times using animal infestation shampoos. Although she called an exterminator who found no evidence of fleas, she did not believe him. She reports her infestation worries began after her sister's diagnosis of invasive cancer, the onset of her own menopause, financial strain, forcing relocation to Argentina, and a recent breakup with her boyfriend. Miss LG described herself as an obsessive person that always had contamination phobia, which historically worsens during times of anxiety. Miss LG claims she is upset about the flea infestation. She reports a history of depression once in the past and was briefly treated with an antidepressant, but otherwise denies depressive or manic symptoms or paranoia. She also denies general medical illnesses, denies use of drugs or alcohol, and denies a family history of psychiatric illness. On mental status examination, Miss LG was calm and easily engaged with normal relatedness and eye contact. She presented a small plastic bag containing fleas and larvae that she collected in the hospital. However, inspection of the bag revealed lint and plaster. Her cognition was intact and her speech had an urgent quality. She described her current mood as sad right now. Miss LG was tearful intermittently, but otherwise smiling reactively. Her thoughts were overly inclusive and intensely focused on fleas. She expressed belief that each falling hair from her head would morph into larva. When crying, she believed an egg came from her tear duct. She expressed an unshakable belief that lint was larva and she was infested. Her insight was impaired, but her judgment was reasonably appropriate. She denies being suicidal or homicidal and denies hallucinations. Miss LG's dermatological examination revealed no flea infestation, burrowing insects, or larvae were embedded into her skin, and no excoriation, lesions, or hyperpigmentation on the skin. On neurological examination, she was alert and oriented ×3, head computed tomography scan, laboratory tests, and toxicology data are all normal. 3 differential diagnoses have been identified: obsessive compulsive and related disorder. If an individual with OCD is completely convinced that his or her OCD beliefs are true, then the diagnosis of OCD with absent insight, delusional belief specifier, should be given rather than a diagnosis of delusional disorder. If an individual is completely convinced that his or her body dysmorphic disorder beliefs are true, then the diagnosis of body dysmorphic disorder with absent insight, delusional specifier, should be given rather than a diagnosis of delusional disorder. Under schizophrenia and schizophreniform disorder, delusional disorder can be distinguished from schizophrenia and schizophreniform disorder by the absence of the other characteristic symptoms of the active phase of schizophrenia, which is continuous signs of the disturbance for at least 6 months. This 6-month period must include at least 1 month of symptoms or less if successfully treated that meet criteria A, such as the active phase symptoms. Under depressive and bipolar disorders and schizoaffective disorder, if delusions occur excessively during mood episodes, the diagnosis is depressive or bipolar disorder with psychotic features. Mood symptoms that meet full criteria for a mood episode can be superimposed on delusional disorder. Delusional disorder can be diagnosed only if the total duration of all mood episodes remain brief relative to the total duration of the delusional disturbance. Based on Ms. LG's symptoms, her final diagnosis is delusional infestation, also known as delusional parasitosis, somatic type. Delusional infestation is a rare monosymptomatic psychosis in which patients firmly believe, against all evidence, that they are infested with insects, worms, or lice that live on the skin and damage their skin. It is psychologically incomprehensible and is not derived from other physical symptoms or daily life events. Bailey et al. 2014 determined the incidence of delusional infestation is more accurately assessed using population-based studies. In their study of 475 identified possible diagnoses of delusional infestation, 64 true cases were identified. The study results revealed there appeared to be a trend for a difference in the incidence by sex, with incidence increasing for both men and women with age, as well as a trend toward an increase in incidence over the past 4 decades. In determining the rationale for Ms. LG's diagnosis of delusional infestation, all of her subjective complaints during her ER visit were considered. The rationale for Ms. LG's diagnosis of delusional infestation was also determined by the presence of one delusion for a duration of at least 1 month or longer. Her insight was impaired versus being absent. Her judgment was reasonably appropriate. Her overall function was not markedly impaired. Her behavior was not bizarre or odd. She denied being troubled by depressive or manic symptoms or by paranoia. Her delusional disorder is not attributable to any substance or another medical condition or mental disorder. And there is no evidence of flea infestation during skin examination. The results of her neurological examination, her head CT, laboratory, and toxicology data were all normal. According to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, American Psychiatric Association 2013, the diagnostic criteria for delusional disorder, somatic type, are the presence of one or more delusions with a duration of 1 month or longer. Criterion A for schizophrenia has never been met. Note, hallucinations, if present, are not prominent and are related to the delusional theme, such as the sensation of being infested with insects associated with delusions of infestation. Apart from the impact of the delusion or delusions or its ramifications, functioning is not markedly impaired, and the behavior is not obviously bizarre or odd. If manic or major depressive episodes have occurred, these have been brief relative to the duration of the delusional periods. The disturbance is not attributable to the physiological effects of a substance or another medical condition and is not better explained by another mental disorder, such as body dysmorphic disorder or obsessive compulsive disorder. Somatic type. This is subtype applies when the central theme of the delusion involves bodily functions or sensations. Evidence-based practice. Ms. LG's delusional infestation may be associated with psychiatric comorbidities and psychological problems. Shaw, Taylor, and Bewley, 2017, explored the extent of psychiatric disorders such as clinical anxiety and depression, and psychological distress such as appearance concern, and other types of difficulties associated with delusional infestation. According to the authors, this study effectively revealed that high rates of psychiatric comorbidities such as anxiety and depression, and psychological problems like appearance concern and poor quality of life exist for patients with delusional infestation. A psychiatric evaluation and, if appropriate, a psychological assessment and intervention for stress rather than the delusional infestation directly should be considered when treating patients with this condition. Various pharmacological treatment modalities have been recommended for the treatment of delusional infestation. Ms. LG could benefit from the use of a low-dose antipsychotic. Generali and Cada 2014 explored the efficacy of Pimozide in adult patients with delusional infestation. The authors determined that Pimozide was effective in this study. 55% of the participants who received Pimozide experienced improvement in or full remission of symptoms with doses ranging from 2 to 4 milligrams, and only 20% of placebo-controlled participants experienced relief or resolution of their symptoms. Delusional infestation is often difficult to diagnose, but early diagnosis and treatment of this condition can avoid costly and unnecessary visits to the emergency room and improve the prognosis of delusional infestation. Sanchez Blanco, and Carnero Gregorio, 2016, examined the effectiveness of delusional infestation treatment for patients referred for psychodermatological consultation after multiple ER visits, but delusional infestation was not diagnosed. The authors indicated that antipsychotics and topical steroids and antihistamines were effective. Olanzapine, the treatment of choice for 43% of participants, showed to be effective for treating delusional infestation with few side effects and did not require special monitoring. Evidence-based practice continued. It is imperative to treat Ms. LG's invisible mental disease, delusional infestation. Psychodermatology is a subspecialty of dermatology which studies the interactions between mind and skin. Shenoy, Prabhu, Nirmal, and Petrawala, 2013, examined the working pattern of a psychodermatology liaison clinic from 2010 to 2012 of patients with chronic delusional infestation and primary psychiatric conditions. The authors indicated that this study validated the need for a liaison psychodermatology clinic was well established, and having a combined clinic allows prompt availability to a psychiatrist, dermatologist, and clinical psychologist at a single visit. Treating symptoms of delusions, especially in cases of delusional infestation similar to Ms. LG, can be particularly challenging, especially when patients are difficult to engage and opposed to the possibility of not actually having a skin disorder. Amid and Bewley, 2013, evaluated the adherence of patients that were on psychotropic and/or dermatological medications for delusional infestation. The study results revealed that 39% of patients adhered to the psychotropic medication prescribed despite secondary non-adherence and failing previous agents due to side effects such as drowsiness. And dermatological medications had a 96% adherence compared to psychotropic medication. Ms. LG's treatment regimen was initiated on the inpatient psychiatric unit. She was started on olanzapine 5 milligrams per day. This is an atypical antipsychotic medication. This drug was selected based on its proven effective results in treating delusional infestation, and it has fewer side effects. No antidepressant medications are warranted at this time. Olanzapine is known to cause significant weight gain and lipid and glucose impairment. However, these side effects may be controlled by administering ranitidine. With regards to the prolongation of the QT interval, olanzapine is still considered the safest new antipsychotic in contrast to risperidone and pimozide. Additionally, olanzapine does not require any special monitoring. Upon discharge, Ms. LG will continue on her same treatment regimen. Since her preoccupation of flea infestation has improved and she developed enough insight to consider her belief that she was infested with fleas was an absurd, crazy thought. And she attributed her temporary break from reality to the multiple stressors in her life. Ms. LG was able to verbalize that her delusions was a distraction from her real problems in life. Ms. LG will be scheduled for a 3-month follow-up to assess medication compliance, effectiveness, and side effects such as EPS symptoms. If her symptoms have recurred, non-compliance would be considered an issue and may warrant medication monitoring from her family members, or olanzapine depot injection may be considered. When Ms. LG has total resolution of her delusional infestation symptoms, olanzapine will be tapered off and discontinued. Ms. LG has been scheduled for weekly psychotherapy visits for 3 months, and she will be reevaluated for continued therapy needs. This slide contains images of other evidence-based treatment options for delusional infestation. However, these medications, excluding olanzapine, can cause unfavorable side effects which can lead to non-adherence and non-compliance of the treatment regimen. Therefore, olanzapine was the treatment of choice for Ms. LG's delusional infestation diagnosis. This concludes my case study presentation for delusional infestation. I hope you enjoyed my presentation.